Okay. I'm Dr. Sara Shaikh, MD, DNB OBGY, and I work as a consultant OBGY in Mumbai. I am MRCOG Part 1 mentor with MedPrepOnline, and today I'll be taking a session on oncology. Oncology is very important from MRCOG Part 1 point of view. Because the topic is so vast, I have chosen this topic so I can summarize all the high yield points. And basically, we can only focus on all the recalls, the classification, staging, and very limited involving the treatment stage. Okay. So now let's begin with oncology. So now, coming to the cancer prevalence, they usually ask you the most common cancer types, right? So the prevalence of most common cancer in women is still lung cancer. The most common gynecological cancer in the UK, so in the developed countries, that is endometrial cancer. If they ask you about the most common gynecological cancer in the developing countries, then the answer would be cervical cancer. Again, the most common gynec cancer worldwide is again cervical cancer. The most common gynecological cancer causing death is ovarian cancer. This is because ovarian cancer is usually diagnosed at an advanced stage when most of the cancer has already metastasized. Why, we'll see later. So most common gynec cancer leading to death, remember, is ovarian cancer. The most common gynec cancer which in pregnancy is cervical cancer. So we'll see cervical cancer usually is a cancer of reproductive age groups. It has bimodal presentation, one peak which is during the reproductive age group and the other which is post-menopause. So because it is the most common gynec cancer that is seen in reproductive age group, it is also the most common gynecological cancer which is seen in pregnancy. Now, as we know, the pathogenesis of cervical cancer is because of the pre-malignant or pre-invasive lesion, which is cervical intraepithelial neoplasia, which is caused by HPV virus. So human papilloma virus, as well as cigarette smoking, these are two independent major risk factors for the progression of pre-invasive lesions to cervical cancer, right? So this is a picture of a normal healthy cervix where you see the cervical os and it's a healthy transformation zone. Transformation zone is the area where we know that the cervix, the endocervix is lined by columnar cells, right? And the ectocervix is lined by the squamous epithelium. So the transformation zone is a zone of metaplasia, right? Where the columnar cells will get converted to the squamous epithelium. Now, this transformation zone is normal, and this metaplasia is a normal change. Metaplasia is basically the progression or the change of one differentiated type of epithelium converting to another differentiated type of epithelium. So very important to remember is that metaplasia, this metaplasia in the transformation zone, which is the squamocolumnar junction, this is not pre-invasive. What is pre-invasive is when there is dysplasia, which is occurring at the transformation zone. And the main causative organism for this is human papilloma virus, right? So human papilloma virus, the virus and genomes will produce the viral products, which will get transcribed into proteins, which is E6 and E7 proteins, very important to remember for HPV virus. So the HPV infection will progress to a low-grade low-grade cervical intraepithelial neoplasia, which will again progress to a high-grade squamous intraepithelial lesion. So now these terms, squamous intraepithelial lesion, have now been replaced by the cervical intraepithelial neoplasia. And once this cell differentiation is lost, there is neoplasia, and because of which there is invasive cervical cancer. So now this is the progression of cervical disease after any HPV infection. So the progression takes almost 10 to 20 years of time to progress from normal epithelium and HPV infected epithelium to invasive carcinoma, which is why screening forms the most integral part of cervical cancer treatment. So it is prevention at an early stage by screening the patient, because these changes, they occur almost 10 to 20 years before the formation of an invasive cervical cancer, right? So now you have a normal epithelium. Once the human papilloma virus gets integrated into the DNA, it transforms the cells, and this HPV infected cell, these are called coelocytes, right? So this will again convert to a SIN1. So these are classified as low-grade squamous intraepithelial lesion. Then SIN2 and SIN3. Now in SIN1, you can see only the basal layers, less than 1/3 of the epithelium you can see is involved. In SIN2, almost 2/3, which is 50 to 75% of the basal epithelium, it's undergone changes, atypical changes. And SIN3, almost the entire epithelium is involved. But here, the basement membrane is not breached in SIN3. So now SIN2 and SIN3 have been grouped together as high-grade squamous intraepithelial lesions. Now, once the basement membrane is breached and the dysplastic cells, these are all the dysplastic cells, they enter the stroma, this forms the invasive carcinoma. So this is how the progression of cervical disease occurs. And again, once the treatment of SIN3 or SIN2, if it is treated at an early stage, these changes do regress to normal epithelium, right? Now the HPV virus, very important points to remember, and each of these are your potential MCQs. So it doesn't just cause cervical cancer, it is predisposing for anal, vulval, vaginal, oropharyngeal, as well as penile cancer in men, very important to remember. So as we know, 16 and 18 are the most important HPV subtypes, and almost 71% of the cancerous cases are caused because of these two viruses. The others, HPV 13, 31, 33, 45, 52, and 58, all of these are also classified as high-risk HPV viruses, and these form about 19% of the remaining cases. Now, because of this, now we realize HPV being the most important, most crucial factor for the pathogenesis of cervical cancer. Now, the screening of cervical cancer has shifted from cytology to an HPV triage. So now we focus on detecting the high-risk HPV. Concomitantly, we do the cytology, and that is how you screen patients for cervical cancer. Now, the low-risk types are HPV 6 and 11, and we know these are causative for anogenital warts. Now, HPV is detected in over almost 99% of cervical cancer cases, right? So the reverse is also true. 99% of cervical cancer cases, you will find the etiopathogenesis to be because of an underlying HPV infection. So now you have vaccines, right, for HPV virus. They do ask you about the bivalent, quadrivalent, and the nonavalent vaccines. So bivalent vaccines, these are against HPV 16 and 18. Quadrivalent vaccine is against 6, 11, 16, and 18. So it offers protection against both anogenital as well as the invasive cervical cancer. And the nonavalent vaccine covers all the low risk as well as the high risk HPV subtypes. Now coming to the NHS cervical screening program. This is a very, very important and hot topic for RCOG. And there has been a recent update in the NHS cervical screening program. And they've incorporated a few additional points, as well as they've changed a few of the parameters of the screening algorithm. So here I've just summarized what you need to know. First invitation, initially it was after 25 or after 30 years, after completion of 30 years. So now the first invitation for screening is at 24.5 years, that is 24.5 years. Now, between the age of 24.5 to 49 years, you will screen the individual for every 3 years. But between the ages of 50 to 64 years, the cervical screening is every 5 years. So this makes sense, right? Cervical screening is done in the reproductive age group, which is the major age group for development of an invasive cervical cancer. Now, 50 to 64 years, obviously, if your initial screening between the reproductive age group has been negative all year round, all 3 years, every 3 years, then the patient is screened every 5 years. Now, the routine screening will end at or after 60 years. And if this meets the criteria for automatic ceasing. So automatic ceasing is when patient has already completed the follow-up, which is from 50 to 64 years, every 5 years. So we end it at 60 years. So if at 60 years, you have to screen the patient, the screening will be coming at the 65th birthday. So that time you will not screen the patient. You will end the screening at 60 years, right? And another important point that they have included, that patients can voluntarily withdraw. That means the individuals from the population whom you are screening. Patient has nobody from the population has developed the disease, but you're screening patients, so they can voluntarily withdraw from this program. Now, high risk HPV, how do you manage. So you triage the person by doing a high-risk HPV testing, right? So if you have a positive high-risk HPV test and an abnormal cytology, so you have two positives, right? So when two positives are present, you directly go for a colposcopy, right? If you find areas of dysplasia or abnormal areas on colposcopy, then you can take a colposcopically directed biopsy. Now, if you have a positive high-risk HPV result, right? So you have a one positive, but you have one negative cytology. That means you've done a pap smear, but the pap smear is negative. But still, your high-risk HPV has come out to be positive. So what you'll do is you'll repeat the high-risk HPV testing after 12 months. Why do we do this? Because the normal immune system of the body, it has the capacity to eliminate the HPV virus. So you give 12 months time to the body's immune system to kick out the virus so that the epithelium regenerates and goes back to normal. So again, you'll repeat the HPV test at 12 months, right? Now, the patient comes out to be negative at 12 months. That means the body has been successful in eliminating the HPV virus. So the person goes back to the routine recall. So if that is between 24 and a half to 49 years, then you will screen them every 3 years. If the patient falls in the category of 50 to 64 years, then they're getting screened every 5 years. Now you've done the HPV test, and instead of negative, you get the same scenario. Again, you're getting a positive result, and again, you're getting a negative cytology. So again, you give the body 12 months time to undergo regression. And again, you test the patient. So now if the patient has come out to be negative at 2 years, you have to send the patient for routine recall. So anytime you're getting two negatives, you send the patient for a routine recall. But in spite of this, still if you're getting a positive result, you've given the patient 24 months, which is 2 years to clear the HPV infection. So now you have to investigate further. You can go for a colposcopic directed colposcopy, and accordingly you can do an SOS biopsy. Now, if your high-risk HPV has been negative from the start, that means you have to send the patient for a routine recall, unless your pap smear is showing either borderline endocervical cases, or this HPV testing, which you did, was basically for a follow-up. That means you have treated a patient of SIN2 or SIN3 by, say, a laser or a cold knife conization, or you've done a LETS or a LEAP, and now you're following up the patient. Even if the high-risk HPV test comes out to be negative, you still continue your follow-up. You don't just omit the follow-up and leave the patient, right? You have to continue the follow-up as stated for SIN1 or SIN2 or SIN3, right? In other cases, as well as in cases of borderline endocervical, if your cytology is showing borderline endocervical changes in your pap smear, even if your high-risk HPV is coming out to be negative, you do not send the patient to routine recall. You investigate the patient further. So this is the summarized algorithm for NHS cervical screening program. So you have an high-risk HPV negative, patient goes for routine recall. If it is positive and the cytology is also abnormal, then obviously you will go for a colposcopy. Two positives, you go for a colposcopy. Now, again, you have a high-risk HPV positive, the cytology was negative, you give the body time for 12 months. If it comes out to be negative, you send the patient for routine recall. Again, you get the same scenario. Again, you give the time of rescreening for 12 months. And in this case, if it comes out to be negative, then again, you can send the patient for routine recall. But here, you get the same scenario with a high-risk HPV positive. And irrespective of what your cytology is, now whether your cytology has come out to be negative, even if it is inadequate or if it is abnormal, irrespective of that, you will be doing a colposcopy, because consecutively for 24 months, you're still getting a high-risk HPV positive. So you cannot ignore it. Now, coming to the progression, now we saw on how a normal epithelium looks like. We can see all of the cells which are normal, even including the basal cells. Now, SIN1, you can see only the lower one third of the basal epithelium is involved. In SIN2, you can see almost up to 75%, and SIN3 is right up to the topmost part of the epithelium. So this arises from the transformation zone, which is the squamocolumnar junction, and the dysplastic cells are distributed in the layers of squamous epithelium for varying thickness, which occurs almost 10 years prior to this entire process. Takes around 10 to 20 years prior to the invasive cancer. So you can see there is the cytological changes that you see. The cytoplasm is reducing, and you can see the nucleus is increasing in size. So result of which is the nucleus cytoplasm ratio is increasing as the grade of lesion progresses, right? So this is typical of loss of cellular differentiation. That means the cells are becoming more and more dysplastic. So SIN1 is mild dysplasia. You can, as we saw, we can give the body time to clear the infection. So you can do conservative management. They regress spontaneously. But you have to follow up the patient by doing both a high-risk HPV testing as well as cytology every 12 months. And you treat if the lesion is persisting for more than 2 years. Just like we discussed, even after 2 years, if you're still getting a SIN1, you have to treat the patient, or if the grade increases from SIN1 to SIN2. Now, SIN2 is a moderate dysplasia. The treatments involved are excisional treatment, which is large loop excision of transformation zone, as well as loop electrosurgical excision procedure. Now you have ablative treatments like laser coagulation and cryotherapy. You don't have to know the particulars or details. Just remember that these are the treatment modalities. And conservative management may be done in special circumstances. Like, for example, if SIN2 is diagnosed in pregnancy, then you may want to defer the treatment until after delivery. Now, in SIN2, because this is a higher grade of dysplasia, obviously you will be following the patient up more frequently. So HPV testing as well as cytology will be done at 6 monthly intervals, and then you will do it yearly. Now, coming to severe dysplasia, which can progress to carcinoma in situ, you have the same modalities of treatment. Only difference is here you'll do HPV testing as well as the cytology at every 6-month intervals, then every year, and this will be continued for up to 10 years, right? Now, take-home message for the NHS cervical screening program, all you have to remember are these important points, and this will help you to crack any MCQ. So always, if you have a high-risk HPV positive, you have to do a cytology, right? Now, if you're having a high-risk HPV positive, as well as abnormal cytology, so both the things are positive. Cytology is also positive, as HPV is also positive. So you'll be going ahead with a colposcopy. Now, if you have any high-grade cytology, like we discussed, if you have a borderline glandular cell are involved, okay? So you are seeing borderline changes in the endocervical cells. So this automatically converts the cytology grade to a high grade. So this patient will need to have a biopsy. That is what we discussed, right? Colposcopy. These are the exceptions who will need a biopsy at colposcopy, and they will be on a 2-week wait pathway. So instead of making them wait for a prolonged time, like the usual waiting time up to 18 weeks, you will transfer the patient to a 2 weeks wait pathway. Now, if you have an abnormal colposcopy, right? So you see abnormal changes in the cervix on a colposcopy. If it is SIN1, then we discussed that follow-up is acceptable. So you can wait for 12 months. But if it's SIN2 or higher, then you need to treat the patient. Always you have to undergo some form of excision, whether it be laser or cold knife or CO2 or LETs or LEAP. And you have to follow up with a test of cure. So test of cure, again, you have to do a high-risk HPV plus cytology. So I hope this makes it clear. I've tried to summarize and make it as clear and simple and palatable for you as possible. Now, moving on to the next is cervical cancer. So from the different epithelium lining, the different epithelial types which line the cervix, we have different types of cervical cancers, right? So the most common and most important type, as we know, is squamous cell carcinoma. So this can be keratinizing, this can be non-keratinizing, it could be papillary, basaloid, warty, verrucous, squamotransitional, as well as lymphoepithelioma type. We also have clear cell adenocarcinomas developing in the cervix, and adenocarcinomas which could transform into endocervical, mucinous, biloglandular, or endometrioid. Other very rare cell types are serous carcinomas, adenosquamous, glassy cell adenoid cystic, adenoid basal, small cell carcinomas, as well as undifferentiated carcinomas. Now coming to the most common type, which is squamous cell carcinoma. So invasive cervical cancer. So what we see is these are large cells. You can see a lot of abundant cytoplasm. It's completely stained pink, right? So abundant eosinophilic cytoplasm. And you can see the nucleus. The nucleus is vesiculated, and you have different sizes of nuclei. They're not uniform in shape. So you have different sizes of nuclei all over the epithelium, right? You'll see some abnormal mitotic forms also. And squamous cell carcinoma is the pathognomic feature of which is you'll find keratin pearls, right? So in keratinizing type of squamous cell carcinoma, you will see a distinct keratin pearls, right? And now you have the entire stroma is infiltrated with lymphocytes. So invasive cervical cancer, remember, it's the most common type. The peak age is around 60 years, and it usually presents as a fungating or ulcerative growth. It spreads locally as well as via lymphatics. So now very important is this FIGO staging of cervical cancer. So always remember the broad classification. Now, stage 1 is confined to the cervix, right? Stage 2 is the carcinoma is invading beyond the uterus, but there is no extension to the lower 1/3 of the vagina or the pelvic wall, correct? Now, in stage 3, again, the lower third of the vagina is involved, as well as the pelvic side walls are involved, and this can also involve the ureters. It can lead to hydronephrosis. It can cause back changes and result in a non-functioning kidneys, right? And it may or may not involve the lymph nodes. And stage 4, it's extended beyond the true pelvis. So it could either involve the bladder or rectal mucosa, or it can spread to the distant organs. So again, stage 1, now the criteria for the lateral extension has been removed. So this is the revised staging. So please pay attention. So stage 1, you have the stage 1, as we can see, is divided into 2. Stage 1A, where the stromal invasion. Here we are only talking about the depth of the stromal invasion. That is less than 3 millimeter. That's all you have to remember, right? And stage 1A2, it's between 3 and 5. Okay. Now, naturally, if stage 1A2 is between 3 and 5, we are progressing to 1B1. So now 1B1, it is more than 5 millimeter, but it is less than 2 centimeter. Correct? 1B2 is more than 2, but less than 4. And 1B3 is more than 4 centimeter. So usually the macroscopic carcinomas are from 1B2, where they are visible to the naked eye. So 2 to 4 centimeter is 1B2, and 1B3 is more than 4 centimeter. Now 2A, which is only involving the upper 2/3 of the vagina, that's also divided into 2 subtypes. 2A1, sorry, is less than 4, 2A2 is more than 4. Correct? And 2B is again the upper 1/3 of the upper 2/3 of the vagina, but there is also parametrial involvement. So you have the ligaments, the round ligaments, uterosacrals, you have the parametry also involved. Now coming to stage 3, which is also involving the lower third. Correct? Now we discussed the stage 2, which was upper 2/3 of vagina. Stage 3 is lower third of the vagina. So 3A is lower third of the vagina, but there is no extension to the pelvic wall. In 3B, very important and very frequently asked question is when the extension occurs to the pelvic side wall. So obviously, when the extension occurs to the pelvic side wall, the first and most important structure to be involved is the ureter, right? So you may have a hydronephrosis or a non-functioning kidney, which automatically makes the stage 3B. Now 3C are the lymph nodes. So 3C is divided into type 1 if only the pelvic lymph nodes are involved. If it goes beyond that, it's 3C2, which is paraaortic lymph nodes. Now stage 4 is when your extension is occurring to the pelvic organs, adjacent pelvic organs like the bladder as well as the rectum. But this doesn't include the edema. It has to be the mucosa. These have to be biopsy proven that the mucosa of the bladder and rectum are involved. So that is 4A, and 4B is distant organ spread. Now, stage-based management of localized cervical cancer. So obviously, only the initial stages, as we know, are operable, and later you give palliative chemoradiotherapy. So in 1A1, you have all the options. Patient can undergo a total hysterectomy. They can undergo a radical hysterectomy or conization if you need a fertility sparing surgery. In stage 1A2, 1B, or 2A, again, you have the option of radical hysterectomy as well as combining it with, now you need more aggressive treatment. So radical hysterectomy with pelvic lymphadenectomy, as well as patient may require external beam radiotherapy. If the patient requires a fertility preserving surgery, right, then you may go ahead with a vaginal trachelectomy, which is only for very early stages like stage 1A2, and in 1B1 only if the size of the tumor is less than 2 centimeter, right? So it has to be a microscopic tumor, not a macroscopic tumor. Only then can you conserve the cervix. Now, for very high risk features such as when you have positive lymph nodes, as well as if in spite of doing a surgery, a thorough surgery, you still have positive surgical margins or the parametry are involved, then you will treat the patient with a cisplatin based chemotherapy. So all the modalities of treatment are involved here. Okay. Now the next stages are all advanced stages. So here mostly you give cisplatin based chemotherapy with radiation. So you give chemoradiotherapy as palliation. Now, cervical cancer in pregnancy is also a very important topic from RCOG point of view. So how do you screen the patient in pregnancy? You follow up the patient, especially if the patient is having the cervical glandular intraepithelial neoplasia. So if glandular cells are involved, or if it is SIN2 or SIN3. SIN1 can be routinely follow up after the pregnancy, but if it is CGIN or SIN2 or SIN3, then you have to continue the follow up during pregnancy as well, right? Don't delay the cytology. So colposcopy again is safe during pregnancy, and in case these tests are inconclusive, then you can do a pelvic MRI. CT scan is contraindicated in pregnancy. You only use it if you're suspecting distant metastasis like lung or pleural spread. Now coming to treatment in pregnancy, initial stages like stage 1A1. So if you apply your logic, it's understandable that initial stages you may be able to conserve the cervix, you may be able to conserve the uterus. So stage 1A1, but there is no lymphovascular space invasion, right? The tumor cells are not invading the lymphatics or the vascular channels. Then you can do a cone biopsy, which is usually done between 14 to 20 weeks of gestation. These patients may additionally require a cerclage, right? Because now we've done a cone biopsy, this weakens the cervix. We've done an iatrogenic procedure. Iatrogenically, we may cause preterm labor. So this may require you to do a cervical cerclage, and this patient can undergo a vaginal delivery at term. But now if you have a stage 1A1 and there is lymphovascular space invasion, either you can do a simple trachelectomy or you can delay the treatment, DTAD. DTAD is you can delay the treatment after delivery, or the patient can receive neoadjuvant chemotherapy, which is after 22 weeks. Once organogenesis is complete, you can give the patient chemotherapy during pregnancy, as well as you can do an elective. And these patients, you have to remember, will deliver by elective LSCS. Now, advanced stages, radical hysterectomy. If the patient decides not to continue the pregnancy, you can go with the radical hysterectomy with bilateral salpingo-oophorectomy, as well as bilateral lymphadenectomy with the fetus also in situ. Okay, so either you do a termination of pregnancy, follow up with the surgery, or you can do it as an elective procedure together. Now coming to endometrium, so the pre-invasive precursor lesion for most of the endometrial cancers is endometrial hyperplasia. So the causative, the etiology of endometrial hyperplasia, let's see them one by one. Obesity, menopause, polycystic ovarian syndrome, estrogen replacement therapy, functioning granulosa cell tumor of the ovary, as well as any excessive ovarian cortical function. So like if you have a stromal hyperplasia, all of this cause unopposed estrogen. So this unopposed prolonged estrogen stimulation of the endometrium finally leads to an endometrial hyperplasia. Now coming to the histopathology, this is the normal endometrium, and we see how the glands and cysts look like, right? So you have A will show you the normal endometrium, and now we can see how the glands as well as the crypts have dilated cystically, right? So we can see cystic changes in the glands. So this is cystic endometrial hyperplasia. It is characterized by varying sized glands. So you can see not one gland has a uniform size. They are large, cystically dilated, and you can see the epithelium is very thinly lined, atrophic. Very scanty mitosis is there, and there is no atypical features. So it resembles the parent epithelium, but they have some cystic glandular changes. And you can see now the stroma, which is present in between the glands, that has become very sparse, not as you see in the diagram A, and it has become edematous. And now next we come to the other types of hyperplasia. So you have endometrial hyperplasia without atypia. So here it again resembles the normal endometrium, but you have very crowded glands. They are of varying sizes and shapes. They are irregular, but the cells again, they do not appear atypical. They still resemble the normal endometrial glands. So in endometrial hyperplasia without atypia, you have increase in the size and number of glands. Again, they are irregularly shaped, and they are lined by multiple layers of tall columnar epithelial cells. So you can see the stratified epithelia. You can see all of the cells which are lining the glands. They are very tall columnar cells, and you can see that the basal polarity has been retained. They are still, the nuclei are still lying basally, right? Now you can see the stroma is densely packed. It's quite cellular. There's no significant atypia, and the risk of progression is less than 5% in the next 20 years. Now coming to endometrial hyperplasia with atypia. So here you can see there are a lot of glands, right? Now the number of glands have increased as compared to the stroma. There is a loss of the normal perpendicular orientation to the basement membrane. So they are very irregularly placed throughout the epithelium, throughout the endometrium. And you have nuclear atypia. So whatever cells are lining the glands, they have undergone atypia. And you will see again, they have crowded glands, irregular shapes and size, but here the cells, most importantly, the cells which are lining the epithelium, you can see this loss of polarity, the nuclei are again irregularly shaped, and they have gone atypical changes. So again, loss of basal polarity, very irregular and hyperchromatic nuclei, very prominent nucleoli can be seen, and there is alteration of the nuclear cytoplasmic ratio. Now coming to causes of postmenopausal bleeding. So this is how you screen a patient of postmenopausal bleeding, and the reasons for this can be various. So most importantly, when we have a patient presenting to us with postmenopausal bleeding, we think of a malignancy, but most of the time it is a benign condition. It could be the polyps, it could be a simple atrophy, the senile atrophy of the endometrium or the vaginal mucosa. It could also be endometritis. Malignancy could be any and all of the genital cancers. Pre-malignant changes like endometrial hyperplasia, like we just discussed, as well as iatrogenic if the patient is on hormone replacement therapy, if the patient is on anticoagulant therapy or post-radiation. So whenever you have a patient presenting with postmenopausal bleeding, transvaginal sonography is the first sign of investigation, followed by biopsy, and you may or may not have to do an hysteroscopy depending on the indication. Now, if you have a postmenopausal woman and she's completely asymptomatic and you've done a ultrasonography for any other reason, say for a genitourinary or a gastrointestinal cause, and you get an incidental finding of a very thick endometrium, if it happens to be more than or equal to 11 millimeters, even if the patient is asymptomatic, you have to treat this, you have to investigate further, right? Now, if a woman is coming, always remember, so if the patient is coming with postmenopausal bleeding, as well as on doing a transvaginal sonography, you are finding a thickened endometrium, then please go further ahead with the biopsy. All right. And another important thing you have to remember is if you get a heterogeneous endometrium on the USG, on the TVS, as well as you get a cystic change in the endometrium, then this is more suspicious of a malignancy. Now, hysteroscopy will only be done in the following indications, and please remember these because they are potential questions for your exam. If you get a benign or inconclusive histology, but you're getting persistent symptoms, so patient keeps coming back to you with irregular vaginal bleeding, or like we discussed, you have ultrasonographic findings of heterogeneous endometrium plus cystic changes, but your histology, that is the pipil biopsy, which you've done, has come out to be inconclusive, right? Now, second, if you have any thickened irregular endometrium on TVS, if you get recurrent or prolonged bleeding, or if you get a non-diagnostic sampling. If all else fails, then MRI may be useful. Now, coming to the algorithm for management. So if you have endometrial hyperplasia without atypia, you have to address and correct the risk factors. You can observe. The first line of management is always a levonorgestrel intrauterine system, which is a Mirena. Also, you can treat the patient with oral progesterone. So this is for endometrial hyperplasia without atypia, because we saw the risk of progression is hardly less than 5% in the next 20 years. But atypical hyperplasia has to be treated because they can progress to cancer in almost 25 to 50% of cases. So the treatment of choice is the total hysterectomy with bilateral salpingo-oophorectomy. But in case the patient requires fertility or if surgery is contraindicated for some reason, then again, you have to address the risk factors. You have to, you can put a Mirena, you can offer the patient oral progestogens, and patient will be on follow-up, right? So you have to follow up the patient by doing a consecutive endometrial biopsy. So if it is only without atypia, then it is every 6 months. If it is atypical hyperplasia, which you are managing conservatively, it is every 3 months. So please remember, these are very important points. Without atypia, it's only for 6 monthly biopsy. With atypia, it's for 3 monthly biopsy. Now, on biopsy, you could have 3 possibilities. It could either regress, it could persist, or it could progress, right? So if it regresses, well and good, you can continue the Mirena for the next 5 years. If it's progestogen, you can stop it after 6 months. And if the patient continues to have abnormal uterine bleeding, you can offer them a total hysterectomy. If it persists, again, you can offer them the option of total hysterectomy. If it progresses, then again, you have to review the treatment and you have to manage it according to the local cancer guidelines. So coming to invasive endometrial cancer, it's the most common gynecological malignancy in the Western world. So please remember, the most common gynecological malignancy in the Western world is endometrial cancer, whereas in the developing nations, it is still cervical cancer. It is also overall the most fourth most common cancer in women. So we saw endometrial hyperplasia is its precursor, and the age group most commonly seen is 50 to 65 years. Now, 90% of women will present with postmenopausal bleeding. Not all postmenopausal bleeding cases are because of endometrial cancer, but the reverse is true. 90% of women will present to you with postmenopausal bleeding. So most are adenocarcinomas, and these are termed as endometrioid adenocarcinomas. Why? Because of their resemblance to the normal endometrium. So most important risk factors, if they ask you for endometrioid type of endometrial cancer, that is age as well as obesity. So as we saw that more than 85% of endometrial cancers, they are diagnosed in women who are more than 55 years. As well as for obesity, you have to remember that if for every additional 5 BMI, that is 5 kg per meter square of BMI, the risk increases by almost 50%. Also, very important to remember, if you have started a patient on hormone replacement therapy, it's been almost 6 months. And so for 6 months, you give the patient a trial or a waiting period, because the hormone replacement therapy is known to cause some unscheduled bleeding. But if this unscheduled bleeding, it persists for more than 6 months after starting your HRT, then the patient has to be investigated. Now, coming to Lynch syndrome, which is an autosomal dominant inheritance, it is a defect in DNA mismatch repair, right? The genes involved are MSH2, MLH1, MSH6, and PMS2. And all of these genes are very important and have to be remembered for your exam. The most important of which is MSH2. So this Lynch syndrome, patients who suffer from Lynch syndrome, they have a 25 to 60% increased risk of endometrial cancer, right? So this is quite high. And mostly these cancers will present at a younger age group. So how do you screen? How do you manage such patients? You have to screen women with Lynch syndrome by doing an annual transvaginal sonography. They have to undergo hysteroscopy as well as endometrial biopsy. So these will not be your blind samplings. They won't be pipple biopsies. They'll be hysteroscopy and targeted biopsies. And you have to start screening them at an earlier age, after the age of 35. So they have a lifetime risk of developing all the three cancers, CEO, colon, endometrial, as well as ovarian. So the risk of colon cancer is almost 80%, endometrial is 30 to 50%, and ovarian is almost 10%. Now, coming to the risk factors as well as the protective factors. So we saw increasing age, obesity, as well as insulin resistance, diabetes, hypertension, PCOS, early menarche and late menopause, nulliparity, as well as unopposed estrogen HRT. In genetic, we have Lynch syndrome, Cowden, as well as if there is a family history of endometrial or colon cancer, physical inactivity, as well as Western type of diet. And iatrogenic would be if a patient has been treated with tamoxifen for breast cancer. Now, the opposite of which will be the protective factors, right? So if a patient has a healthy diet, if they've undergone a bariatric surgery for weight loss, as well as high levels of physical activity. Parity, later age at birth, later menarche, as well as OC pill use is associated with, which is continuous combined hormone replacement therapy. These are protective factors. Breastfeeding is a protective factor, right? Now coming to histological types. So WHO histopathological types, these are 7. So endometrioid carcinoma, as we saw, the most common, the adenocarcinomas, mucinous type, serous type, clear cell adenocarcinomas, undifferentiated carcinomas, neuroendocrine tumors, as well as mixed carcinomas. So mixed carcinomas, they are composed of more than one type, and they have at least 10% of each component. Now coming to the types, the broadly endometrial carcinoma is divided into two, type 1 and type 2. So type 1 is always estrogen dependent, and type 2, there is no estrogen involved. Type 1, it presents in perimenopausal age group, and type 2 is mostly seen in postmenopausal women. So the precursor lesion for type 1 is an atypical hyperplasia, and for type 2 is an intraepithelial carcinoma. So type 1, because these are estrogen dependent, they are low-grade tumors, and type 2 are high-grade tumors. So because they are low-grade, there's minimal myometrial invasion, whereas the myometrium is deeply involved in type 2 tumors. So type 1 are very important to remember, are endometrioid carcinomas, and type 2 are the serous and clear cell. So always remember the serous and clear cell carcinomas, which are type 2 related, have a worse prognosis, right? Endometrioid carcinomas have a good prognosis. So the genetic pattern, because they are indolent, they have an indolent nature, and they are not rapidly growing, whereas type 2 carcinomas are usually slow growing. These are very aggressive tumors. So now type 1 genetic mutations, very important to remember, like we discussed Lynch syndrome, so microsatellite instability, P10 mutation for Cowden syndrome, as well as KRAS. So these three are the important genetic factors involved, whereas for type 2, it is P53 mutation. So please remember this table, because the genetic factors as well as the histological subtypes are your recall questions from MRCOG. Now, endometrial carcinomas are divided into well-differentiated, moderately differentiated, as well as poorly differentiated. So in well-differentiated, you will have the glands arranged. This will resemble somewhat the parent epithelium. It will resemble the endometrium. So you have back-to-back crowding of the glands, and the intervening stroma is obliterated. The epithelium will also show some stratification. There'll be tufting, there'll be various papillae and atypia, and this is the most common subtype. So luckily, the most of the carcinomas that are detected are well differentiated. Moderately differentiated are the same as differentiated, but they have quite solid sheets of malignant cells. In poorly differentiated, there is a loss of architectural pattern as well as cytological atypia. So there'll be marked cytologic atypia, and very rarely will you find the endometrial glands. So now coming to the FIGO staging of endometrial cancer. So stage 1, now this also has been newly updated in 2023. So stage 1 is confined to the uterus as well as the ovary. So 1A is when the disease is limited to the endometrium itself, and it's a very non-aggressive cancer. So these are low-grade cancers, right? So they have a good prognosis. So 1A1 are the low-grade non-aggressive cancers, but they're limited to either a polyp in the endometrium or confined to the endometrium. 1A2 is involving less than half of the myometrium, and 1A3 is, these are low-grade endometrioid carcinomas, and they're limited to uterus and ovary. In 1B, there's invasion of more than half of the myometrium, and in 1C, you have aggressive. So up till 1B, we were discussing about the non-aggressive types, and in 1C, you have aggressive histological types. Now, stage 2, there is invasion of cervical stroma plus lymphovascular space invasion. So here we had discussed in 1C, the aggressive histological types are only confined to the endometrium. So now in stage 2, they will progress to the myometrium. So coming to stage 2, 2A, there is invasion of cervical stroma. In 2B, there is lymphovascular space invasion. And in 2C, you have aggressive histological types involving the myometrium. Now, stage 3 is direct invasion of the uterine serosa or adnexa. So 3A is again divided into 1 and 2. So 1 is when the spread is to the ovary or fallopian tube, and 1A2 is when the uterine serosa is involved. Now 3B is when the vagina and the parametry are involved. So 3B is again divided into 1 and 2. 1 is when the vagina and the parametry are involved, and B2 is when the peritoneum is involved. Now 3C constitutes the pelvic and para-aortic lymph node spread. So 3C1 is pelvic lymph node, and out of which 3C11 is micrometastasis, 3C12 is macrometastasis. Now 3C2, you have invasion of the para-aortic lymph nodes. And these para-aortic lymph nodes are up to the renal vessels, right? So again, divide into 1 and 2, which is micro and macrometastasis. Stage 4, as previously it was in the FIGO staging, it involves the bladder as well as the rectal mucosa, as well as distant metastasis. So 4A is bladder mucosa or bowel mucosa. 4B is any other additional peritoneum is involved, which is beyond the pelvis. And 4C is when there is distant spread to liver, lungs, and bone. Now coming to the next tumor, as we can see, there's a whorled pattern of cells. You can see the spindle shape of the cells, and they're arranged in fascicles or whorled pattern. So here you have the smooth muscle cells with elongated or spindle shaped cells, and there's an abundant eosinophilic cytoplasm. The nuclei also we can see are elongated. They are oval or blunt with a blunt end, and this is typical cigar shape. You can see the interlacing fascicles. So this is nothing but leiomyoma. The age most commonly is 30 to 44 years, and the commonest type is intramural or interstitial. So whenever you have a patient presenting with leiomyoma and pain, it could be either degeneration, it could be torsion, or it could be expulsion. And most of the leiomyomas, they do not cause any problems with fertility, except submucosal, which may rarely cause infertility if it is indenting the endometrium or if it is causing distortion of the uterus. Now coming to the FIGO staging, so now you have 0, which is a submucosal pedunculated intracavity. So it's completely inside the cavity of the uterus. 1 is when it is also submucosal, but it is less than 50% inside the intramural. So you can see most of it is submucosal, very less part of it is in intramural. 2 is again submucosal, but more than 50% is gone intramural. 3 is when it is 100% intramural, but you can see the edge of it is in contact with the endometrium. 4 is when it is completely intramural and no part is in contact with the endometrium. 5 is when you have a subserosal tumor, but almost more than 50% is still inside the myometrium. So it is more than 50% intramural. 6 is when you have a subserosal tumor, but less than 50% of it is intramural. 7 is when you have a subserosal tumor, which is pedunculated, right? So completely subserosal, not in contact with the intramural, not in contact with the myometrium or the endometrium. And type 8 is when you have cervical or parasitic tumors. So now when do you operate on a leiomyoma? So we know most of the time we manage them conservatively. But what are the indications for surgical treatment, they ask you? Either if the patient comes with heavy or prolonged bleeding, if it's a large tumor which is almost more than 14 weeks size, even if it's asymptomatic, if there is growth after menopause because we are worried about malignant changes, if it is causing acute retention of urine, if it is causing an obstruction of labor, or if it has a chance of undergoing torsion. So what are the degenerative changes which are most frequently seen? So atrophy, which obviously occurs post-menopause because of diminished blood supply. Hyaline degeneration, which is the commonest. Here you have homogeneous eosinophilic substance, right, which is the hyaline material. It gets deposited inside the leiomyoma, and the muscle fibers will undergo necrosis, and eventually there is liquefaction of the hyaline material. So it becomes very soft because of liquefaction. Next, you have calcification. This occurs if there are pre-existing fatty deposits in the leiomyoma. So if they have fatty deposits, they'll undergo calcification. There'll be phosphates as well as carbonates of calcium, which will get deposited along the blood vessels, and this will give a typical appearance, which is a womb stone appearance. So if there is calcification of the entire leiomyoma, it will present as a womb stone. If only the periphery of the leiomyoma or the fibroid is calcified, then it will give a typical eggshell appearance. Then you have myxomatous as well as cystic degeneration. You have red degeneration, which or the Carney's degeneration, which occurs in pregnancy. Here the center becomes necrotic. What happens is the growth of the fibroid, it overshoots its blood supply, right? So it outgrows its blood supply, because of which the center of the fibroid, it undergoes necrosis. It stains red or salmon pink. On staining, the fibroid itself stains red or salmon pink in color. You'll see it is purplish red because there is thrombosis of the blood vessels involved, and it can undergo infection by coliforms. So in very rare cases, you may find a very peculiar fishy odor if the fibroid is undergoing, if it is infected, secondarily infected by coliforms. We'll just take a break here for 5 minutes. Let's continue. Now, this is very similar to leiomyoma. You have whorls of smooth muscle cells, right? These are spindle shaped. Again, they have abundant cytoplasm and oval nuclei. But you can see that there's loss of some architectural pattern. The whorls are not that distinct, right? The shape of the cells, the smooth muscle cells, is also irregular. And they have more cytoplasm, and the shape of the nuclei is also changed, right? So this is progressed to leiomyosarcoma. Just a moment. The diagnosis here is leiomyosarcoma. Just a moment. Now coming to the next type, which is endometrial stromal sarcoma. So these will spread through vascular channels, right? So now you can see through the picture, most of the cells are in the stroma. So the entire stroma has been invaded. There is no glandular structure, and all of the neoplastic cells are present in the stroma. So these are hormone sensitive tumors, and they recur locally. Now coming to ovarian tumors. So what are the different types of adnexal masses that we see? Benign ovarian tumors are usually functional cysts. Then you have endometriomas, serous cystadenomas, mucinous cystadenomas, and mature teratomas, which are the most common seen in reproductive age group. Benign non-ovarian are usually paratubal cyst, any hydrosalpinx, tubo-ovarian abscesses. If there are pseudocysts, appendiceal as well as diverticular abscesses, and a pelvic kidney. In malignant ovarian tumors, the most common type is epithelial carcinomas. Then you have germ cell tumors in the reproductive age group, as well as less than 20 years. Then you have sex cord stromal tumors. Secondary malignant ovarian tumors are predominantly arising from the gastrointestinal carcinomas as well as the breast. Now, ovarian tumors are usually classified into benign or malignant by ultrasonography findings. So this is the IOTA group classification. So you have B rules and M rules. So B rules are easy to remember. They are unilocular cysts and they have solid components. So always remember, solid components are present in both. So you have solid components in B rules where the largest component is less than 7 millimeter. They are clear unilocular cysts, so there'll be acoustic shadowing. They are smooth. They could be multilocular also, but they are smooth. And the largest diameter is always less than 100 millimeter. Plus, there is no blood flow. Now, in M rules, you have very solid tumors which are irregular. These are not cystic. They are solid irregular tumors. there are at least 4 papillary structures, there is presence of ascites. And because they both can be multilocular, so in case of malignant tumors, they are irregular, multilocular, as well as solid tumors. So remember these buzzwords, they are irregular, multilocular, and solid tumors, and the largest diameter is more than or equal to 100 millimeters. So when it is equal to 100 millimeters, please classify it under malignant. And they have very strong blood flow, which is characteristic of a neoplasia or malignancy. Now coming to premenopausal ovarian cyst and the management, which is usually asked as a case scenario in RCOG. So always remember, if you have a premenopausal woman coming to you with a diagnosis of simple ovarian cyst on a TVS, then you do not have to test the patient for CA125. You have to, however, do an LDH, an alpha-fetoprotein, and HCG if the woman is under age of 40 years and there is a presence of a complex cyst on USG. So always prefer transvaginal sonography more than a transabdominal sonography because it is more sensitive. And an RMI calculation, which is a risk of malignancy score, risk of malignancy index, has to be calculated for patients presenting with ovarian cyst of any kind in all age groups, right? So even for premenopausal or postmenopausal, we'll be doing an RMI calculation, which is U into M into CA125. So U is basically the ultrasound result. Now, ultrasound score is scored as 1 point for each of the following. Either it could be multilocular, it could be a solid or metastatic or ascites or bilateral. So these are 5 points which you have to remember, right? So multilocular, solid, metastasis, ascites, and bilateral. It is 0 if there is no score. If it is 1, then you have a score of 1. And if you have 2 to 5 points, right? If you have, say, multilocular as well as there is presence of ascites, then the score will become 3. If you have multilocular as well as metastasis as well as bilateral, then the score again will become 3. Now, next you have a menopausal status. So if it is premenopausal, the score is just 1. And if it is postmenopausal, it is scored as 3. Now, for serum CA125, whatever is the absolute measure, which is given in international units per milliliter. So remember, if there are small tumors, which is supposed less than 5 centimeter in diameter, they generally do not require follow-up because, as we know, most of these cysts are physiological, they are functional ovarian cysts, and they will resolve within 3 menstrual cycles. However, if you have a premenopausal woman coming to you with a cyst of size 5 to 7 centimeters, then you should undergo a yearly ultrasound follow-up, right? Because these cysts may enlarge, and these large simple cysts again may undergo torsion, right? So if there are larger cysts, you can advise the patient even to undergo a MRI, or you can advise them to undergo an elective laparoscopic cystectomy. Now coming to management of postmenopausal ovarian cyst, right? Now for postmenopausal, a size of even 1 centimeter, you will have to be very cautious because any cystic lesion in a postmenopausal patient can progress to a malignancy. So for these patients, you have to do a CA125. So you will be doing a transvaginal sonography along with a transabdominal if it is inconclusive. You will be doing a CA125 as well as you will calculate the RMI score. So the cutoff is 200. If it is less than 200, you know the patient has a very low risk of malignancy. And again, now you'll classify if the cyst is characteristics are fulfilling all of the criteria. Like suppose the patient is asymptomatic and this was an incidental finding. If it is a simple cyst, if it is less than 5 centimeter, if it is only unilocular and unilateral. So all of the simple benign features, then you will consider the patient for conservative management. So what is conservative management? You don't just leave the patient, you have to follow them up. So how often will you follow them up? Every 4 to 6 months, the patient will again have to undergo a CA125, a transvaginal sonography, as well as a calculation of the RMI score, right? I hope this is simple now. But now if the patient who had an RMI score of less than 200 has other features, right? They have, the patient has come with symptoms like pain or bloating or pelvic pain, pressure, irregular spotting or bleeding, right? And if there are some non-simple features, like the patient has a cyst of more than 5 centimeter, if it is multilocular, if it is a bilateral, then this is quite suspicious for malignancy, and you may offer a patient a salpingo oophorectomy, which will be bilateral in this case, right? So whenever you're operating for a patient of CA ovary or a postmenopausal cyst, which is suspicious of a malignancy, always the patient undergoes a bilateral salpingo oophorectomy. Now you know if the RMI is more than or equal to 200, always remember more than or equal to 200 as well is a characteristic of malignancy. Then you have to undergo further investigation. The patient has to undergo imaging. You have to do a CT scan as well as refer the patient to a multidisciplinary team for gynecological review. If there is a very high likelihood of ovarian malignancy, then patient has to undergo a full staging laparotomy, which is done by a gynecologist. If it is a low likelihood of ovarian malignancy, then again, you can undergo a total abdominal hysterectomy with bilateral salpingo oophorectomy with omentectomy, as well as you'll do some peritoneal washings or samplings. And this can be done by any gynecologist. So if it is a high likelihood, always the patient is operated by a gynecologist, gynecological oncologist. Now coming to the next, which is ovarian cancer. So ovarian cancers are also divided into type 1 and type 2. And type 1, they are slow growing and confined to the ovary. They develop from well-defined precursor lesions, and they could be borderline tumors also. They are genetically more stable. The more common genetic abnormalities associated with are KRAS and BRAF. And the most common subtypes are mucinous and endometrioid. Whereas for type 2, these are rapidly growing and aggressive tumors. They don't arise from any particular precursors. Since these are malignant tumors, they are highly genetically unstable, and most of them arise from P53 mutation. Most common subtype is serous carcinoma. So please remember, for type 1, it is mucinous as well as endometrioid type of ovarian carcinoma, whereas for type 2, it is serous carcinomas, which are high grade. Again, the age group most commonly is 50 to 70 years, and most important to remember are 80% of the ovarian cancers are epithelial cells in origin. Now coming to the FIGO staging for ovarian cancers, which has been simplified in this diagram. So as well as the 5-year survival rate, which they usually ask you. So 1 is when it is limited to the ovaries, 2 is when it is limited to the pelvis, 3 is when it is spread to the abdomen, and 4 is when there is distant metastasis, which has occurred outside the abdominal cavity. So in 1A, only one ovary is involved. 1B, so B stands for B, so both ovaries involved, bilateral. And 1C is when the tumor has ruptured and come to the surface of the ovary. So either it could be a ruptured capsule, or there could be surface excrescences, which is surface tumor, or you could have positive washings. Patient may have ascites. Now 2A is when the tumor is confined to the uterus as well as the fallopian tubes. In 2B, other pelvic structures are also involved, like your ligaments as well as round ligament, uterosacrals, and the likes, the peritoneum, the broad ligament, these are involved. Now in 2C, you have all of the above, plus there is positive peritoneal washings, or there'll be presence of ascites. In 3A, you have microscopic metastasis. In 3B, you have macroscopic metastasis, but it is still less than 2 centimeter. In 3C, there is macroscopic metastasis, which is more than 2 centimeters, as well as involvement of regional lymph nodes like pelvic and paraaortic lymph nodes. In 4th, there is distant metastasis outside the abdominal cavity. So it can involve the bladder, the rectum, as well as it can involve the distant organs. So 5-year survival rate for stage 1 is almost up to 90%. For stage 2 is 45 to 60. For stage 3 is 30 to 40. And for stage 4 is the worst prognosis, which is less than 20%. So if they ask you overall survival rate for ovarian cancer, it's around 44 or 45%. Now coming to the benign tumor, which is serous cystadenoma, you can see these are multiloculated cysts. They have very thin walls, and the cyst content is very clear, right? So this is serous fluid. And very subtly, you can see on the surface, they have some subtle papillary excrescences. So ovarian serous cystadenomas, the different types of papillae you can see, which are projecting into the lumen of the cyst. And the epithelium is ciliated columnar, as well as the collagen is very dense. So again, multilocular cyst with papillary ingrowths, which are projecting into the lumen, and they're lined by columnar epithelial cells. So these are benign changes. Now coming to the next. So now you have some microscopic features, as we can see in the picture. Low columnar epithelium, and it lines the cyst, as well as the presence of few psammoma bodies. So this is very particular of anaplastic tumor cells. Whenever you see some psammoma bodies, these are particularly seen in the papillary type of serous cystadenocarcinoma. So these are malignant changes. And this picture shows you typically what a psammoma body looks like. So you can see the central eosinophilic material, which is lined by the columnar epithelial cells. So papillary serous cystadenocarcinoma, you see multi-layered malignant cells, and there is loss of polarity. You'll see solid sheets of anaplastic cells, as well as you can see the invasive neoplastic cells have entered into the stroma, right? You can see both the places in both the diagrams. You can see clearly there is stromal invasion. Presence of psammoma bodies, and these patients usually present very late, hence they have a very poor prognosis. There's also omental spread, and origin of most of the serous cystadenocarcinomas is from the fallopian tubes. Now coming to the next, you can see these are multiloculated cysts, right? So they are mucin secreting columnar epithelium, and it is interspersed within the goblet cells. So these goblet cells are secreting mucin, which is present in the lumen. So you can see these are separated again by the fibrovascular septa. So piled up malignant epithelium at places, you can see a lot of different patterns. They could be solid, papillae, as well as stromal infiltration, and there'll be pools of mucin. Again, you can see the picture with stromal invasion as well as mucin in the lumen of the cells. So this is mucinous cystadenoma. So coming to the next type. So you can see here the lumen of the cells. These are clear and you can find some intracellular components, which is glycogen. So here you have clear cell tumors, which are characterized by tubules, right? So you have tubules, you have glandular pattern, you can have papillae as well as solid sheets of tumors. And these are clear cells. They have abundant eosinophilic cytoplasm, as you can see, and they are rich in glycogen. Now coming to the next type, these are germ cell tumors. So of the germ cell tumors, they are almost 15 to 20% of all the ovarian tumors. Now, of which the most common is a dermoid, which is a mature cystic teratoma. These will arise from totipotent germ cells and they can occur in all age groups. So mostly they are seen in reproductive age groups. So if they ask you the most common germ cell tumor, which is found in pregnant patients, it is a mature cystic teratoma. They are bilateral in almost 10 to 20% of patients and malignant degeneration is seen in almost 1%. So here you can see, because they arise from totipotent germ cells, you will see different mesodermal tissues. So you can see here cartilage, you can also see some fat cells, right? And different types of epithelium involved. Now coming to the next type of tumor, you can see here very distinct shape of the nuclei, which with a central groove, right? So these are coffee bean nuclei, and these are seen in Brenner tumor. So Brenner tumor consists of nests. There are masses as well as columns. So different types, and this epithelium is commonly the transitional epithelium, which is seen in the genitourinary tract. So these are transitional epithelial cells, and they are scattered throughout the ovary in the stroma. So you can see it's invaded the stroma as well as in the glands. And these tumor cells are ovoid in shape, having a clear cytoplasm. The nuclei have a groove, which is called as coffee bean nuclei, and these are mostly benign. Now coming to the next type of germ cell tumors, these are dysgerminomas. So here you can see there are lobules, right? So you can see fibrous septae are separating the tumors. The tumor cells are mostly uniform. They are round to polygonal cells, and the nuclei are hyperchromatic. They are arranged in lobules, and they are divided by fibrous septa. And the fibrous septa have a lot of lymphocytic infiltration. So again, they are arranged in diffuse sheets and islands, as well as cords, which are separated by scanty fibrous stroma. The tumor cells themselves are uniform in appearance. They have vesicular nuclei, clear cytoplasm. They are also rich in glycogen. This is the commonest germ cell tumor, which is a malignant germ cell tumor. They ask you in a benign, it is a mature cystic teratoma. So it's a female equivalent of seminoma, and they are almost bilateral in 20% of cases. Now coming to the next type, this is very commonly seen in a yolk sac tumor. This is a Schiller-Duval body. You'll see the epithelial cells, the neoplastic cells, which are characteristically surrounding a blood vessel. So this is pathognomonic of a yolk sac or an endodermal sinus tumor. So there are papillary projections having a central blood vessel, and there is a perivascular layer of embryonal germ cells. So you can see around the blood vessel, there are embryonal germ cells in the Schiller-Duval body. Now, next you have a granulosa cell tumor. These are the commonest malignant sex cord stromal tumors. Usually, these are unilateral. They could be hemorrhagic, and they have a propensity for a late recurrence. Now, because they are estrogen producing, very commonly, they can cause a precocious sexual development in youngsters in less than 18 years of age, as we can see. And they can also lead to the formation of endometrial hyperplasia, which may progress to cancer. So they have a very microfollicular pattern. As you can see, follicles are formed with central rosette-like bodies. So you can see a central round pink mass, it is surrounded by a row of granulosa cells. So the reason it is called a granulosa cell tumor is because it originates from the specialized epithelial cells, which are the granulosa cells. So they surround the round pink mass, and this is forming a rosette body, which is called as a Calixner body. Now coming to the next, now you can see this kind of a tumor, it appears to be very solid, right? And there are certain mucoid areas which have undergone degeneration. There's also some mucin produced, and the entire ovary has been effaced, such as by looking like a adenocarcinoma of the stomach. So this is a Krukenberg's tumor, and very characteristically, you can see the signet ring cells. So the metastatic tumor, it will closely mimic a primary ovarian cancer. It can look like a primary ovarian cancer, but the origin is from a primary gastrointestinal tract. So most common, it can occur from the uterus, the colon, the stomach, the biliary tract, as well as the pancreas. But most commonly, these arise from the stomach. So mostly they are bilateral, and you'll have bilateral enlargement, bilaterally enlarged solid tumors of the ovary. And you can see the characteristic signet ring cells, which are filled with mucin, and all of them are clustered together. Now coming to the last and most important is vulval disorders. So vulval disorders are usually characterized by two types. Either you have a usual type of vulval intraepithelial neoplasia, or you have a differentiated type of vulval intraepithelial neoplasia. So in older women, you can find DVIN, which is the differentiated type, and the precursor of which is lichen sclerosis. So chronic long-standing lichen sclerosis can develop into DVIN, which is again a precursor of invasive vulval squamous cell carcinoma, as well as keratinizing squamous cell carcinoma are seen in older women. Whereas in younger women, what you see is UVIN, which is the usual type of vulval intraepithelial neoplasia, and the precursor of which is HPV infections like 16, 18, 31, and 33. They are mostly warty or basiloid type. So squamous cell carcinomas are usually seen in older women, whereas the warty as well as the basiloid squamous cell carcinomas are seen in the younger age group. Now coming to the differentiated type, it is again associated with lichen sclerosis, and the undifferentiated type or the usual type, which is also called classical, it is HPV associated. So this is what the first type, which is differentiated, looks like. It occurs on the it occurs basically superimposed on the lichen sclerosis lesions. And this is what the undifferentiated or the classical types looks like, which is having the anogenital warts as the precursor. Now coming to vulval intraepithelial neoplasia, you can see hyperkeratosis, which is thickening of the epithelium, parakeratosis, as well as acanthosis. So there is differences in the size and shape of the cells. You have coelocytosis as well as atypical cells, and this can be seen throughout the entire thickness of the epithelium. Once again, the basement membrane will be intact here. There is also increase in mitosis as well as lack of any surface differentiation. So there is loss of any polarity, and you can see atypical cells which are scattered throughout the epithelium. Also, vulval intraepithelial neoplasia, it can exist with vaginal intraepithelial neoplasia. Now coming to frank cancer, which is squamous cell carcinoma, it's the most common malignancy, epithelial malignancy, which occurs in the vulva. So for vulval lesions, is the most common type, and particularly it occurs, it's a disease of old age. So it occurs post-menopause, which is classically at around 70 years of age. The patient can present with a lump or can present with a mass, and patient may present to you even with chronic pruritus. In almost 50% of the cases, the chief complaint is pruritus. So the major external genitalia that is involved is labia majora in almost 60% of cases, minora in 20%, the clitoris is involved in 12%, and perineum is involved in 6% of cases. So vulval squamous cell carcinomas are important because they spread through all the three routes. They can have hematogenous spread, they can have lymphatic spread, as well as direct spread through to the other direct to the parametria. Now the treatment for vulval squamous cell carcinoma depends upon the staging. It could be either a wide local excision, it could be a vulvectomy along with neoadjuvant chemotherapy with or without lymphadenectomy, right? So most important for vulval squamous cell carcinoma, you have to remember are the lymph nodes that are involved. So the staging of the disease as well as the treatment, the prognosis, all of it is dependent upon the lymph node status. So the most foremost lymph nodes that are involved are the inguinal group of lymph nodes, followed by the femoral group of lymph nodes. Now, the prognosis, as we saw, is dependent upon the size of the tumor, what is the depth of the underlying invasion of the epithelia, the invasion of the stroma, as well as what is the degree of differentiation, whether they are well differentiated or poorly differentiated, and the nodal metastasis. Now, coming to the FIGO staging of carcinoma of the vulva. So this is very short and concise. So when you have a tumor which is confined to the vulva, if it is less than 2 centimeter in size, and the invasion of the stroma is less than 1 millimeter, then it is classified as 1A. So these 1A tumors are almost superficial tumors, and the risk of metastasis is almost negligible. Whereas for 1B, the size will be more than 2 centimeters, and the stromal invasion will be more than 1 millimeter. Now, the second, you have tumor of any size, and the extension has occurred to the nearby structures. So whenever there is an invasion, or whenever there is a tumor involving the vulva, the adjoining structures are the urethra, the anus, as well as the vagina. So you can have the involvement of the lower parts of the urethra, the vagina, and the anus, but the nodes are negative. Now, in 3, all of the upper parts will be involved. So 3A will involve the upper 2/3 of the urethra, vagina, as well as the anus. That means the bladder and the rectal mucosa can also be involved. Here, the lymph nodes are involved, but the metastasis is only up to the size of the lymph nodes is less than or equal to 5 millimeter. In 3B, the lymph node size is more than 5 millimeter. And in 3C, the lymph nodes are involved beyond the capsule. So there is lymph node metastasis with extracapsular spread. In 4, you have distant metastasis. So 4A can be involving any of the pelvic bones, or it could be a fixed lymph node. So when you have a fixed or ulcerated lymph node, please classify it as 4A. And 4B involves distant metastasis. So that's all for oncology. Now coming to questions. So let's come to the first question. Yes, who wants to read this? Anyone who is online can unmute themselves and read the question. Yes, Shireen St. John. Shireen, do you want to go ahead?
A 62-year-old is taking tamoxifen following surgery for breast cancer. She is experiencing some vaginal bleeding. A transvaginal ultrasound measures endometrial thickness at 7 millimeter. How should she be investigated next? A dilatation and curettage, hysteroscopy and targeted biopsy, MRI scan, no investigation, PP endometrial biopsy. Tamoxifen is yes, it potentiates agonistic features on the
Yes, correct. Correct. I really appreciate the way you attempted the question. So it's an agonist at the endometrium. So what do you think it does?
Yes.
It stimulates the endometrium, right? So that can
Yes,
lead to
lead to endometrial hyperplasia.
Correct, and eventually can cause cancer. So what would you like to do next?
I think I'll go with the hysteroscopy and targeted biopsy.
Perfect. So that's the correct answer.
Yeah.
Right? So the answer is B, hysteroscopy and targeted biopsy. Right. Next, who wants to read the next one? Shireen, if you're online. Go ahead, read. We'll solve the question as you read it.
Okay.
John, you want to go ahead? Yeah.
Yeah, a 55-year-old is referred to gynaecology for postmenopausal bleeding.
Yeah, postmenopausal.
Yes, ultrasonography reveals thickened endometrium with small ovarian mass on the left side. Endometrial papil biopsy shows grade 1 endometrial carcinoma. Our CA125 is 150 units per mil, and inhibin B levels 100 nanogram per liter.
Yes, she undergoes total abdominal hysterectomy. Continue.
Ovarian mass in that case.
Sorry? Yeah.
Mm.
So she undergoes total abdominal hysterectomy, and the diagnosis of ovarian mass in her case, what do you think it is?
Type grade 1 endometrial carcinoma. That should be.
Again, if you're discussing grade 1 endometrial carcinoma, we're usually talking about type 1. And type 1 are mostly estrogen dependent. So you have something which is causing unopposed estrogen production, stimulation, right? So what could it be? Which one of the tumors we know to secrete estrogen?
Granular cell tumor.
Yes, perfect. Right? So granular cell tumor, because it is the cells, it secretes estrogen. And in youngsters, it will lead to precocious puberty, whereas in older age groups, it can lead to carcinomas.
Carcinoma, yes.
Yeah. Very good. Yeah. Next one. Yeah. Please go ahead.
Patient was symmetrical. Patient had symmetrical bilateral ovarian tumors removed. HP revealed tumor cells with signet ring morphology and raised possibility of metastasis rather than primary ovarian malignancy. What is the most primarily likely site? Signet ring, that's Krukenberg tumor.
Correct. So stomach. Yeah, that's right. So this is a very favorite. Yeah, so this is a very favorite question of the RCOG. Which they ask about the primary for Krukenberg's tumor, which is stomach.
Stomach, yes.
Yeah. Next.
What type of VIN is associated with the greatest risk of prognosis to vulvar
squamous cell carcinoma?
Squamous cell carcinoma. Differentiated non-differentiated. I think is
So what they're basically trying to ask you is which type of vulval intraepithelial neoplasia has the worst prognosis, which can develop into an invasive proper carcinoma, like a squamous cell carcinoma involving the vulva.
I'm not sure. I think it's C, undifferentiated, has to do with leaching sclerosis.
Yeah, so this is the reason I put this question, because we usually tend to think that an undifferentiated carcinoma type will progress to an invasive cancer. But here, differentiated and undifferentiated is with regards to the pre-invasive lesion. So here, differentiated type is the answer, and it is arising because of a long-standing lichen sclerosis, right? So differentiated type has more chances of progressing to a vulval squamous cell carcinoma. So please remember, it's a very important recall from MRCOG.
Okay.
Now coming to the next question and the last.
So, okay. Differentiated, all right.
Yeah, differentiated is the answer.
Yeah. A 4-year-old presents with vaginal mass that appears as a cluster of grapes protruding from the introitus. Our mother reports intermittent vaginal bleeding. What is the most appropriate first-line management for this condition? First-line management, 4 years. I think I will go with hormonal.
What do you think the condition is? Let's diagnose the condition first. It's a 4-year-old. Okay. See the buzzwords. It's a 4-year-old. There's a vaginal mass. Okay. It typically appears like a cluster of grapes, and it's protruding from the introitus. What kind of cancer presents at the age of 4? So clearly it appears to be a vaginal cancer, right? Because the child is presenting with intermittent vaginal bleeding. So this is a type of vaginal cancer, if you can guess. Okay, so it's sarcoma botryoides. Okay, so sarcoma botryoides, it's a type of embryonal rhabdomyosarcoma. So it commonly affects the vagina in young girls. So usually they'll present with a polypoid, grape-like mass protruding from the vagina and lead to intermittent bleeding. So here the first line of management is chemotherapy plus surgery. So you will have to give chemotherapy first to shrink the size of the tumor. Then you do
Okay.
surgery. Patient may require chemotherapy later to prevent any
Okay.
recurrence, right? So this is the
Okay.
answer. Answer is E.
E. All right. Chemo and
Okay,
surgery. All right.
so that's all
Excellent.
for today's session. If you have any questions, you can ask them here or you can post on the group. And I hope you all enjoyed it. I hope it was informative and I hope it helps you for your preparation. Okay, so all the best to all of you for all of your preparation, and I'll meet you all in the next lecture. All right, thank you.
Yeah. All right. Thank you so much.
Thank you.
Thank you so much, madam. It was very informative. Thank you so much.
You're welcome, my dear. Please go through the recording and whatever questions, whatever doubts you have, feel free to post them on the group, right?
Thank you, doctor, for recording because I have joined it late.
No
Inshallah,
issues.
I will go with.
Yeah. That's fine.
So nice.
All right, bye.